Welcome to the Health Leader Forge, a joint production between the University of New Hampshire and the Northern New England Association of Healthcare Executives. My name is Mark Bonica, and I am an assistant professor in the University of New Hampshire's Department of Health Management and Policy. Today's guest is Steve Ahnen, the president and CEO of the New Hampshire Hospital Association. The New Hampshire Hospital Association is an independent, nonprofit association representing the interests of the hospitals in the state of New Hampshire. Steve joined the New Hampshire Hospital Association in 2008 after spending 16 years in progressive leadership roles with the American Hospital Association in Washington, D.C. In this podcast, we talk about the role of both the American Hospital Association and the New Hampshire Hospital Association and what it is like to work as an industry advocate at the national and state levels. I hope you enjoy listening to Steve's story, and if you find it valuable, won't you leave us feedback on iTunes, Stitcher, Spotify, or wherever you might be accessing this recording? It helps other people discover us. Thanks for listening. And here is Steve Ahnen. Welcome to the podcast, Steve.
Good to be here.
So, Steve, you went to the University of Kansas and double majored in political science and German. So I'm curious, what brought you to the University of Kansas and why those majors?
I grew up in Kansas City, so lifelong Kansan. And, I didn't have a whole lot of choices about where I was going to go to college. It was going to be a state school. Both my brother and sister went to that other university down the road, and my brother was still there, and I didn't want to be the same school he was in. So KU was really a great choice and a good fit for me.
Yeah. Yeah. And were you already thinking about going into the field of politics and policy, or was it something you kind of landed while you were in school?
No, actually, I went to college and I was going to be a business major, right? Everybody, okay. What else are you going to do? So I was in the business school for, I think, 1 year and learned pretty quickly that probably wasn't the right place for me, and took a political science course that I just found fascinating and really enjoyed it. And, decided pretty much on the spot that was the path I was going to go down. And German was just that was kind of fun for me. I had taken German in high school, and I knew I was going to continue to take, a class or two. And I thought, well, why not take a extra class or two and end up with a major? And ultimately actually spent a year studying abroad in Germany as well.
Neat. So did that interest in politics build? How did you, because your first job out of school was as a legislative aide for two members of Congress for Kansas. So, that's kind of a big jump to just a passing interest to a pretty intense engagement.
Yeah, so when so as I said, I studied abroad my junior year, came back and ended up needing another year to finish my undergrad, just because I couldn't take all the courses I needed to while I was studying abroad. And my last semester as an undergrad, I spent in Washington as an intern at a little nonprofit group called the Congressional Management Foundation. They still exist today. They do a lot of work sort of on the management side of Congress. So think of them as a management think tank for congressional offices. And they do a salary survey, a tenure survey of Hill staff. And it was a fascinating opportunity to really get the insight of what happens on Capitol Hill, but not so much from a political perspective. When I was choosing, what internship I wanted to do, a lot of people chose to do an internship on Capitol Hill. I steered away from that because most of what I had heard some of my predecessors that had done those worked for Senator Dole and others, and they ended up, basically walking the dog and getting his, dry cleaning. And I thought, that really doesn't sound like a whole lot of fun. So I actually had an opportunity when I was at the Congressional Management Foundation to do some work on how does a congressional office sort of manage its constituent correspondence, and because if you can't respond to constituents' letters and requests and those things, you're not going to generally, get reelected very often. And so one of the things that I did was a study on, how they organize their offices, how they organize their filing systems and the like. So again, it was a very different focus, that it wasn't a political focus, but it really gave me an opportunity. And it was just by happenstance that I got my first job. I was talking to my professor back at the university, and I said, gee, I'm going to graduate pretty soon, and I'm trying to figure out what am I going to do? I'm going to come home, and maybe there's some opportunities at the state capitol in Topeka. And he said, have you looked out the window? Do you know where you are? You're like in the center of the political universe.
Yeah.
Have you thought about working in Washington? And I thought, well, I guess, yeah, that'd be pretty cool. And literally 2 days later, he calls me back and he says, hey, I just got a phone call from Congressman Whitaker's office, and they're looking for a junior legislative aide, somebody coming right out of college, something you think you'd be interested in. Does it match your politics? And so that's literally how I got my first lead on that job. And then the work that I'd done at the Congressional Management Foundation really spoke to the kinds of things that they were interested in terms of just my background and all of that. So, literally, that's how I got my first job. I started literally a week after graduation, and, kind of the rest is history. But what's interesting, how I got my start in healthcare. When I started, I was not the healthcare legislative aide. And in fact, Congressman Whitaker served on the Energy and Commerce Committee and the Health Subcommittee, which has pretty broad oversight of a whole host of things, Medicaid, Medicare Part B, and Food, Drug, Cosmetic Act, and a whole lot of things. The woman who was managing those issues, after about 6 months that I was there, her husband got a new job and they left town. And so they were trying to hire somebody. So, serving on that committee, they really wanted somebody who really understood those issues. And then midway through that search, he announced he was retiring. So he had about a year left of his term. And as soon as he announced he was retiring, there was really no one who knew anything about healthcare that was going to be interested in taking a job that literally only lasted 12 months. Now, jobs on Capitol Hill, everybody that takes those understands, that's a real possibility that your boss could retire, they could lose. But you always want to sort of land someplace where you have some longevity. So not having an ability to hire somebody who knew anything, they said, hey, Steve, what are you doing? Do you want to do healthcare?
Oh.
And I thought, hey, that sounds kind of interesting. This, it's a big issue and lots of things going on. I'm sure I'll try that. And that's literally how I got started in healthcare. And it was just, fascinating. So I graduated in May, and in September, the Congress is working on budget reconciliation, and I'm sitting in a room. And again, I'm in the bleachers. I have no immediate role, but I'm sitting there. Dan Rostenkowski, Lloyd Benson, all these titans of Congress, and I'm going, oh my God, look at where I'm at. And so that really was kind of the beginning. And Capitol Hill was such a great place to get a start in my career, because in some ways it was a lot like college, because you had to research issues, you had to find out a lot about stuff, you had to pull lots of information, condense it, and present it to your boss in a way that they could understand, that met the interests of the constituents of the party and all of those things. And so I just found it fascinating. It was a lot of fun, and for a kid from Kansas, sitting in the room with these titans of Congress, that was pretty heady stuff.
That is really neat. So had you had like any health experience, or did you take any health classes? Like this was just like, hey, figure it out on the fly.
I'd been to the doctor a few times, and that was pretty much it.
Nice.
And it was fascinating. I remember my first day on the job, Congress was considering changing how physicians were paid, and really trying to increase reimbursement for primary care physicians, sort of moving away from some of that specialty thing. And I'll never forget the woman who was the lobbyist for the internal medicine docs. They're doing their job, they're walking around, and they, coming in to chat. And so she comes in and she sits down and she says, I'd really like to talk to you about why, increasing, the relative value scale for primary care is really important and all this. And I just looked, I said, hey, Laura, can you do me a favor? Today's my first day on the job with this issue. Could you maybe back up a little bit and tell me why it's important that we reform physician payments? And so it was, I literally was learning by fire hydrant, right? It was just all coming at you. But, that was fun. And it was an opportunity to really learn and to have an impact on something that was a lot bigger than just you.
I just want to pause for a second because that's really interesting. But your internship, where you actually chose, instead of being focused on policy, you were more focused on kind of the mechanics of how those offices run. I mean, that kind of runs back to your like, hey, I should be a business major, and then you changed your mind. But then you wound up focused on like kind of nuts and bolts management kind of question. That must have actually made you more appealing, I imagine, just that knowledge to the congressman who actually hired you, because you were coming in with some understanding of actual operations work in their offices. That's kind of neat.
Yeah, and actually, that was one of the things that the chief of staff told me later. That was really the thing that kind of tipped the scales in my favor. Because I didn't grow up in the congressman's district. So while I grew up in Kansas, I certainly didn't grow up in his district. So for them, having somebody who understood how an office functions and why it's important that it function well, they felt was really a key key piece in why they ultimately chose me.
I mean, the reason I focus on that is just because I talk to my students a lot about, the experiences that they're gathering, and, you just never know what is going to be relevant and come together for your future plans. So that's a really neat story. So your boss at the time was going to retire in a year. So you had that year to work on health policy. You were in that role for about 3 years. Did you continue with health policy work after he left?
I did. After he retired, I went over and worked for my hometown Congresswoman, Jan Myers, from the Kansas City area, and worked for her for a little over 2 years before I left Capitol Hill. So, and my focus there was on healthcare issues as my main area of focus.
So that's another kind of like, you just kind of randomly landed into this health policy specialty, and then it kind of built, and you wound up doing a total of 3 years working with the Congress people. And what drew you? So from there, you wound up moving over to the American Hospital Association. What made you decide to leave, working directly with the policymakers to working with the Hospital Association?
Yeah, I think for people that work on Capitol Hill, you tend to find folks that, they're going to be lifers, people who will spend their entire careers on the Hill. And then you'll find people who sort of get a start and then decide, I'm not sure this is where I want to spend my entire career, and then find an opportunity to move out. And then you'll get people who kind of bounce back and forth. And you're certainly seeing that, with the new administration, every change in administration at Congress, you've got people coming in and out. I think part of the challenge for me in some respects, as I often reflect on it, I worked for a moderate Republican woman in the House of Representatives at the ascendancy of Newt Gingrich and the Republican, contract with America, and not making political judgments one way or the other, but it was a much more conservative House and House leadership. And my boss was not within that framework. She was a pro-choice, moderate Republican, and just wasn't likely going to, sort of be on that leadership track. Although she ultimately did chair the Small Business Committee in the House. And so, I always said, I felt like kind of that little Dutch boy, always trying to put my finger in the dike, but I never could feel like I could get upstream and really solve the problem. I was always addressing somebody else's, challenges. And so I think I kind of made that decision that, I wanted to do something different where I had an opportunity to make a difference and could impact policy in a bigger way. So as a healthcare aide or a legislative aide, you see lots of different groups coming through the office. You see lots of different advocacy coming towards you. And there are certain organizations and things that you see, you're kind of like, man, I couldn't do that for a living. I couldn't be pushing that rock uphill. And then there are others that you really respect. And, I think what I have learned over the years is a lot of it's really dependent upon people, right? It's relationships, and how organizations behave is how those individuals behave. And the individual who was the lobbyist for our office he was a straight shooter. He would clearly make the case for hospitals, which I expected him to do. But he was also pretty smart about understanding what was the other side of the issue. If I were to say, well, what would the medical association or what would the opposition say about that? And if somebody can give you an honest answer to that, that to me says a lot about that person. And it says a lot about, the organization that they represent. And hospitals are an incredibly important part of the community. They truly are community institutions that are so vital to all of our lives and to the community. And so having an opportunity to work and to represent an organization like that was something that I always said, gee, that if I were going to leave the Hill, that would be the kind of organization that I'd want to go to, and had the good fortune of, stepping in at the right time, and was fortunate enough to land at the AHA.
How did the opportunity actually come about?
The individual that I worked with became vice president in the AHA, and they were looking for a new lobbyist. And so he asked if it was something that I would be interested in, and clearly I was more than interested in working for the AHA. Hadn't always thought about being a lobbyist, but in many ways it was really just an extension of the kind of work that I was doing. And so I said, absolutely, I'd want to move there. And so, just really was fortunate. That was, in the early 90s. So it was right at the end of the H.W. Bush administration and just the beginning of the Clinton administration. And so my focus was going to be on budget and appropriations issues. So think about the incoming Clinton administration and the economic challenges and the significant budget issues and the things that had to happen. And ultimately, sort of the impact on hospitals was pretty groundbreaking kind of stuff at the time.
Yeah, I mean, so you were transitioning in the early 90s. We had a bit of a recession, nothing like what we've seen in recent history, but it felt pretty bad at the time because that's when I graduated from college in those right around that time. And I remember a lot of my friends were not getting jobs and it would look pretty bleak. So that was it was a tough time. So, I mean, you ultimately wound up staying with the Hospital Association, the American Hospital Association, for about 16 years. I want to ask you a little bit about your career there, but first, maybe could you talk a little bit about, what is the American Hospital Association? What does it do, kind of broadly?
Yeah, and that was an interesting period. So when I came, AHA leadership had changed just about a year and a half before. Dick Davidson was the president. He had been the president of the Maryland Hospital Association. And, the AHA is it's a national trade association. So they represent hospitals all across the country. So hospitals of all types, large hospitals, small hospitals, rural, urban, academic medical centers, children's hospitals, psychiatric hospitals, hospitals of all types belong to the AHA. And they belong to the AHA for a lot of reasons. But, one of the primary reasons that hospitals join the association is because of the advocacy and representation work that they do in Washington. And that's actually when Dick Davidson was hired at the AHA was something that they were really focused on, bringing advocacy and representation to as the core strength of what the association did. That was when healthcare reform was really beginning to take shape. The incoming Clinton administration and obviously made that a big hallmark of their campaign. And so the AHA was transitioning. Their primary headquarters was in Chicago, and so all of their staff, their policy staff, their communication staff, their executive staff were all based in Chicago. They had opened an office in Washington in the mid to late 60s when Medicare came into being. But the Washington office was always much smaller. It was really just the lobbyists, sort of the government relations folks, but a much smaller presence. And when Dick came to the AHA in the early 90s, he brought all of that policy communication and housed his office there in Washington. And I think, that's something that's really, really fundamentally important. So much of what happens in hospitals is decided in Washington. So much of their payments are dictated by, Medicare, Medicaid, VA, Champus, and the like. Policies around Medicare, not just payment, but how those programs, function, coverage, all of those things have huge implications for hospitals. I mean, think about an organization that spends, how much time and resources does an organization spend around its philanthropy, right? Maybe philanthropy is 5 or 10% of their overall budget. Medicare, Medicaid, government payment could be somewhere, depending upon the individual institution, 30, 40, 50, 60, 70% or more. And so really the need to really focus on those policy issues is really, really important. And one of the challenges, as I said, you got hospitals of all kinds that join the AHA. So how do you get 5,000 hospitals to agree on an advocacy strategy? And that's a real challenge. And the diversity can be your biggest challenge, but it can also be your greatest strength. And I think that's what the AHA certainly attempts to do. I think it's what it's taught me is, as hospitals, we are different, right? We have big hospitals, small hospitals, rural, urban, suburban, for-profit, not-for-profit. But in the end, there is so much more that unites us, that we have in common, than divides us. So if we focus on that 80, 90, 95% of the issues that really unite us, and we can set those other issues aside, we can be very, very successful. And I think that's what, we certainly have tried to do here in New Hampshire, but I know that's, the AHA's big focus. I think the big change, I think, really around associations and trade groups like ours is over the last probably 15 plus years, the need to be much more externally focused. A lot of the things we've typically done have been focused on, talking to Capitol Hill or, Governor so-and-so and the like. And while that's still really important, it's become much more important to speak more publicly, to speak to actual patients and communities, to help get them engaged in the conversation. If I go talk to a legislator, I can make the case for the hospitals. If the hospitals themselves go speak to the legislators, they can make those cases about why this bill is important or that bill is one we don't like. But if the community can stand up and say, we need to support our community hospital, that's so important and so powerful for legislators, for governors, for members of Congress and the like to hear those messages, because in the end, every vote in Congress, every vote in the State House, every vote counts. And so helping them understand what this means for their constituents is so vitally important to the work that we do in ensuring policy, payment and the like ultimately are aligned to support the work that our members do.
So it is actually important to, if you're a citizen, to communicate with our representatives actually listen and take that seriously.
They do, and it's actually one of the things that I find somewhat frustrating with our own graduate health administration programs, and I'm a product of one of them. Is how much time do we spend sort of talking to students about how important the role of advocacy is? In my own program, we got an afternoon lecture about it, but it's really, really important. And for the work of the association, it's fundamental to our ability to get the job done. And I can say in New Hampshire, it really is the difference between success and failure. I would say the AHA would make that same argument. But certainly at a local level and in a state like New Hampshire, it's absolutely critical.
So you'd been working with Congress for about 3 years. You jumped over to the AHA. What was it like making the transition from being on the policymaker side to being on the lobbyist side?
It was interesting. It was funny actually when I left. So that was the early 90s, and that was at a point where there was more interest and focus on, sort of that revolving door, members of Congress leaving, staff members leaving, and, going to the private sector. And I made Newsweek because I was one of those people, sort of the revolving door. And I had to laugh because they had people like me, and then the individual who was the head of the staff director for the Ways and Means Committee. I was like, this big on the scheme of
25
Congress.
years old.
And here's this person who really knows what, and so I just had to chuckle. I mean, it just happened to be that I left at the same time. And so I got to be part of the story. But, it was fascinating. That was at a point where federal budgets were pretty sleepy. It wasn't rough and tumble political kind of debates. But as Congress was trying to reduce federal spending to limit mandatory spending, Medicare, Medicaid budgets became, pretty political issues. And I think for hospitals, it was really, how do we begin to turn that focus to understanding what it means if we're not going to fund these programs? And so I think on one hand, I certainly felt, man, the momentum has totally shifted the wrong way for a guy whose job is supposed to deliver good budgets to the hospitals. But what I think it taught me was, in the world of policy and politics, you have to take the long view, and you really need to help. Sometimes you have to really help paint a picture of what the implications of certain things are. You need to identify where you need to get to, and then you got to develop those, steps and strategies in order to get there. So I think, for me, it was sort of baptism by fire of really getting thrown in, and how do you make those shifts, certainly bigger than, one junior lobbyist can make them. But I think my job was to help the organization understand the challenges and really fundamentally understand the nature of what we were dealing with. And I'll never forget one of the things that I did. We were always looking at ways. Congress was looking at ways to cut spending. If we cut X, we could fund this, that, or the other. And so I was going through some stuff one day, and the Congressional Budget Office puts out this book. If you cut this program, it saves how many billions of dollars. So I didn't have an axe to grind with any of these, but everybody else was coming up with ways to cut the Medicare and Medicaid programs. So we came up with a list of, well, if we cut X number of B-2 bombers, we can save how many billions of dollars. And it wasn't meant that we should cut B-2 bombers, but it was meant to really identify ways that the federal government could squeeze in other areas than Medicare and Medicaid. So that was one of my first things at the AHA. It's often referred to as the Ahnen list, even today, of different ways you can cut the federal budget. But
B-2 bombers.
But I do think it was sort of instructive in that sort of short-term, long-term kind of perspective that you need to have.
Wow. Well, you were with the AHA for 16 years, like I mentioned. So tell me kind of the arc of your career with the AHA. What was it like? So from junior lobbyist to you left. You left the AHA as a senior vice president for association development. So from junior lobbyist to senior vice president, what were those 16 years like?
Yeah. So, I lobbied for about 4 years directly, and then had the opportunity to become the chief of staff to the president of the association. And, that was one of those sort of plucked out of nowhere. And, the individual who had that role left and took another role within the AHA. And Dick Davidson, was a real believer in, sort of promoting from within and giving somebody an opportunity to kind of step up. And, I would say I was given a tremendous opportunity to take a big leap in my career. But, it was really a great place to learn about leadership, to learn about how to manage an organization, how to manage a board. And I would say Dick Davidson is probably, the person who has had the most, outside of my own parents, has had the most impact on my growth and development, and why I'm sitting in this chair today because of him. And so, I kind of gave up my being, gig and became much more focused on sort of internal operations, focused on managing the senior management team for the president. And that gave me insights into board leadership, functioning of a board, broader policy, member relations, and the like. And did that for a number of years, and then ultimately had an opportunity to become senior vice president and had operational responsibilities under my purview with human resources in our Chicago office. So really became much more internally focused. And then the last few years became a little bit more externally focused. One of the things that we really tried to do, and my last title as association development, was really all around how do we engage with other organizations? How do we engage particularly with the business community? We think about healthcare, hospitals and business have a tremendous amount of alignment on issues, but in many ways we hadn't really talked about that, and in fact probably found ourselves on opposite sides of issues at times. And so we really created a strategy to engage with the Chamber of Commerce, the National Association of Manufacturers, the Small Business, the Retail Federation, and a whole host of folks to really start to understand as healthcare reform moves forward, how do we work together? We did a number of events with the Chamber of Commerce. And I still, to this day, Tom Donahue, who's still at the U.S. Chamber of Commerce. It was just fascinating for business to kind of understand some of the challenges that hospitals are facing, and for hospitals to hear the kinds of challenges that that businesses are confronting. And worked actually with one of the chairman of their board at the time was a gentleman from Wegmans, the big grocery chain. And
people from New England probably don't know Wegmans, but that's like a grocery shopping date night for people, right?
Exactly. But they've done a lot of things around reducing healthcare costs, not necessarily just looking at how much they pay to insure their employees, but really keeping their employees healthy. They launched this initiative, sort of they challenge everybody to put a pedometer on and challenge everyone, how many steps can you get today, and do those kinds of things. But it really was around, sort of that healthy individual kind of a focus, which was certainly something that was very different. And as we think about this whole population health movement, that was really a precursor to all of that.
Again, coming back to that, you made that kind of offhand comment at the beginning. Like, I just did a business major because what else were you going to do? And then you shifted into this kind of political science and policy role. And then it sounds like you actually spent a lot of time in operations.
Yeah, it's interesting. If you'd asked me at age 22, where would I end up? What would I be doing? Sitting in New Hampshire probably wasn't high on that list of things to do, but I had an opportunity to do something that allowed me to learn. It allowed me to grow. It allowed me to give back and to make a difference. And I just kept following that path. I had opportunities, and every opportunity was a new opportunity to grow and to expand, my skills and my abilities. And I followed that path, and I've done that. And it's been an unbelievable career that I've had. I didn't start at the AHA with the notion that I was going to be there for 16 years, but man, it was the best career choice I've made, only second to the one to come to New Hampshire. But I've been able to do things. I've been able to learn, to grow, and to give back. And to me, that's what it's all about, right? And if I can keep doing that, I'm happy to be right here where I'm at and continue to make a difference. I mean, I think that, and you talk to students a lot. What are they,
right,
what are they interested in? And I have kids that just recently graduated college, one in college, and when I talk to them, the things that they're interested in, they want to do good. They want to make a difference. They want to be a part of something bigger than themselves. And to me, that's exciting. And it really, I feel really good about the next generation coming behind us. That they are ready. They're going to be willing to take on a host of new challenges and hopefully solve a lot of the problems that those of us before them made or created for them. But I really do think that there is a lot of hope for the future in that sense.
Yeah, I just love your message, because it's something that I try to drive home with my students. It's like, if you're open, if you're working hard, the opportunities will come, and if you grab hold of them, you might not know what it's going to be, your future is going to be, but as long as I think your story is just great. So
the chief of staff, let me just add one point to that. The chief of staff to my first boss, the member of Congress that I worked for, said something and it's always stuck with me. When I was applying for my next job, since my boss was retiring, he had called and spoke to the chief of staff who I'd interviewed with for my next job, and was giving me a reference. But he said something that's always stuck with me. He said, I said, he's a guy who doesn't know a time clock. He's always going to do everything he needs to do to get the job done. And I thought about that, and at the time it struck me, man, that was a really big compliment, because it meant that I was going to do whatever it took to get the job done. And like you've hired people and had people work with you, and you've had a lot of people who come 5 o'clock, boy, hey, I gotta get out of here. And then those people who they don't look at the clock, they get the job done. Those are the people that you want working with you and for you. And good people are hard to find, and you find one, you're going to hold on to them, and you're going to give them more opportunity, more responsibility. And that's our job is to help them be successful, taking on those additional responsibilities.
Exactly. So in 2008, you did leave the American Hospital Association, and you came to the New Hampshire Hospital Association to be the president and chief executive officer. So you're a boy from Kansas. You've been spending 16 years in DC. What brought you to New Hampshire and the New Hampshire Hospital Association?
Yeah, I think I'd been at the AHA for a number of years, and in fact, frankly, many of my colleagues, I'd been there 16 years, and I still felt like one of the new kids. Many, there've been many who spent 30, 40 plus years of their career at the AHA, and I said, if I'm going to make a change, now's the right time. And I'd always been someone a few steps behind the leader, and I'd had opportunities to lead and do things, but I was always a step or two behind. And I thought, at some point, I'd like to run my own organization. I'd like to step forward and provide that leadership. And so I started to look around, and working at the AHA, you see states and regions of the country. And while I hadn't spent a lot of time in New England, the time I had spent in New England really showed to me that people here, they don't run to government to solve their problems, but they don't run away from government either. And there seemed to be this sense of a real balance that I thought, from a policy perspective, certainly fits my view. I'm not a hard left or hard right, or my view is we need to be pragmatic, and so we sort of work center out. And so it seemed to me that New Hampshire would a state that might be a good fit. So when my predecessor announced he was retiring, I threw my hat in the ring and came up to the first interview, and I said to the search committee, I said, gee, what on earth could you guys be interested in, this guy from Kansas who spent 20 years in Washington, never been to New Hampshire before. Why on earth would you be interested in me? And the head of the search committee, one of the hospital CEOs, looked at me and said, that's a really good question, but I could ask you the same thing. Why are you interested in New Hampshire? And so it was a great opportunity to really explore that opportunity, and think, I certainly hope they feel like, they found that it was a good fit. I know I have.
Yeah, that's great. So folks who don't know these organizations might think, oh, the New Hampshire Hospital Association is the local chapter of the American Hospital Association. Talk a little bit about what is the New Hampshire Hospital Association, and maybe what's its relationship with the American Hospital Association. How is it structured, and what's its mission?
So the American Hospital Association and the New Hampshire Hospital Association are two entirely separate organizations. There's no organizational or bylaw or structural connection in that sense. But we are very much partners in the work that we do. We always used to say when I was at the AHA that the state associations were the AHA's most important strategic partners because we do so much work around policy and advocacy. And that's actually that's absolutely right. We do have some role in appointing members to various AHA policy groups and the like, but I don't report to anybody at the AHA, but we work very closely together. In some respects, it's a handshake. And, we work in partnership to do the work that we do. We couldn't do the federal advocacy work that goes on if it weren't for the AHA. We don't have a staff member who sits and works in Washington and lobbies the delegation down there. So we do rely on them for a lot of that. So, the Hospital Association is, it's a unique organization. As I said, we represent all of the hospitals in the state of New Hampshire. Every hospital is a member. They don't have to be, but every hospital belongs to the association. And we represent hospitals. So we go speak to the legislature, the governor, the federal delegation, and, we speak to the media. We gather information, resources. We provide education to our members. And it's interesting. I often say to our members, I'm not the association. The board hires me. I run the organization. I lead it. But the members are the association. They are the ones who we exist for. If it weren't for the members, who would we be? And so, my job and our job as a staff is to really bring our members together to help them understand the key issues and challenges, and how do we work through those issues? Because what happens in a small hospital or a large hospital, they're all providing care. How do those issues, whether it's an IT or whether it's a clinical issue or whether it's a supply chain issue, those are things that they all deal with. And so our job is to help bring them together. And so one of the things that we do at the association is we bring different groups together. So the CMOs, the chief medical officers, the chief nursing officers, the chief financial officers, the accounts receivables, quality leads, all of those folks, they come together and they work through issues. So right now, there's a whole host of issues around COVID that we're dealing with. But just take, for instance, issues of the vaccine administration and how are hospitals who are going to be key to getting the vaccine to be able to vaccinate their staff, to be able to vaccinate patients in their communities is so fundamentally important. But we have to do that in a way that when the vaccine comes, we can get it to the hospitals and that they can do that in a way that makes sense from a business process, from a regulatory process, from a quality and safety piece. And not everybody looks at everything the same way. And so as we sit and work with our partners in how do we do that, they've got their responsibilities to develop these platforms and these software things and all the rest to get those vaccines out, to do all that administration. And our hospitals actually have to deliver it and put those vaccines into people's arms. And so we've spent literally over the last month, I've spent hours on, Zoom calls with hospital representatives, with chief information officers, with clinicians, and others, and our state partners working through those issues. In some respects, we can boil a lot of our issues down to communication. How are we communicating to one another? How are we managing these issues so that when we roll them out, they can be successful? I can stand up and I can say, well, it should be this way. If the state doesn't do it that way, or if the hospitals don't see it that way, or somebody isn't able to manage it in that way, we've got chaos. And so again, it's really trying to bring all of that together. And I have to say, one of the unique aspects of New Hampshire is this local control, right? Community. I grew up in the Midwest, and I grew up in a town called Prairie Village. I would never, ever say to somebody if I met, yeah, I'm from Prairie Village, Kansas. I'd say I'm from Kansas City. But if you meet somebody in New England, man, they're going to tell you what town they live in, what high school they went to. I mean, and so that local control, that community is so important. And I think that extends into the policy world of what we do and how we do our work. And so people sitting down, working together to solve those problems is a common thing that people are frankly used to, which helps. Now, having said that, I don't want to be Pollyanna. There are differences, right? And government has a set of expectations. The federal government's saying you got to do things this way, and that doesn't necessarily mean that it works the way they want it to for us. And so, we got to figure out ways to work around that. And I think from my perspective, that's where we spend a lot of time, is really trying to figure out how do we make things work? How do we operationalize some of these things so that we can meet the needs of the patients and communities that we serve?
I like your example, because I was going to ask you about COVID, but your example of like the vaccine, of developing a vaccine plan, that's a thing that I hadn't thought about it really, but it makes a lot of sense. Like the hospitals need to kind of come up with a joint plan. This is a shared resource that going to need to have a plan for deployment of that resource, and to have them cooperating rather than competing with each other on that plan is important. And so that's a role that you play in helping them come up with a cooperative, not necessarily to tell them what to do, but to help them come up with a plan that works for them. Is that a fair statement?
Absolutely. Absolutely. And, just again, on this vaccine issue, New Hampshire is the only state in the country that doesn't have what's known as an immunization information system, or a registry system. So when you think about it, and this vaccine is going to be really important because people are going to need to get 2 doses. So when Mark Bonica gets his vaccine, he's going to get dose 1. And depending upon which vaccine it is, X number of days later, you're going to need to get the second dose of that same vaccine. So we need something to be able to make certain that you're getting the same vaccine at the same time, or at the right time, and all of that. And if we don't have that system, where does that reside? So the state is actually attempting to put in place a system right now. It won't be ready for this initial rollout. So we've got this separate system. And so trying to get those systems to talk with the electronic health records that hospitals have, which aren't all the same. And, so those are big challenges. And it's, so we have these conversations, and if somebody were to just look in from the outside, they may think, gosh, those are pretty adversarial conversations. And they're really not, because if we need to get data and information into the system, we got to figure out how we do that. So when the data goes into the system can acknowledge it, and it's useful. So, we push back and forth, and we try and come up with a way to make it happen. And I'm hopeful that, we're going to be able to do so, because it's just so fundamentally important to our ability to stop the spread of COVID-19 and ensure that we can kind of all get back to the kind of life that we want, which is being able to be out and about and all of those things.
Let me just clarify a little something. You talked about you're a membership organization. So there are 26 hospitals in the state of New Hampshire. So the Hospital Association is a not-for-profit entity. It's not a government entity. It's a not-for-profit. So and so the hospitals themselves choose whether they're going to be members or not. And that when you say members, that's who you're talking about. You're not talking about there aren't individual members. Like, I'm not going to join the Hospital Association as Mark. But Wentworth Douglas, my local hospital, or Exeter, that's your members. So when you're talking,
that's correct. That's right. That's right.
And so within what I think one of the interesting things about New Hampshire is the fact that those 26 hospitals break down evenly between critical access hospitals, which is we don't need to go into the definition of that, but small hospitals, and 13 critical access hospitals, 13 PPS hospitals. How do you, I mean, and then we actually, and for folks who don't know the geography of New Hampshire, we've got a pretty significant divide between kind of the North country, we call it the North country, like above the notch, right? So there's this mountain range, and people, and southern New Hampshire is, so most of the population of the states in the South. Also, all the large hospitals are in the South. Well, that's not true. Dartmouth is up in kind of the North country, ish. So, got geography, you've got size. How do you kind of navigate and all that generates different interests between the organizations? How do you navigate those differences of interest?
Well, again, as I said earlier, I think one of the things that we have to focus on, you can focus on the issues where we may not have consensus, or you can focus on the areas where we do. And I think there's far more that unites us than divides us. So, just thinking about the current COVID-19 pandemic, we need one another. We really, truly do. We convene our members multiple times a week on calls where we're sharing information, we're sharing resources and information back to the hospitals, so they can see real time, what's happening in their community, what's happening in others. So as a hospital, as we think about where we are right now, we have a surge of new COVID patients. Hospitalizations are on the rise. How's a hospital going to manage that? If somebody ends up with more patients than they're able to manage today, is there a way that they can find some help from their colleague, in another part of the state or down the road, to maybe take some patients or to bring some resources to them? We actually saw that earlier in the spring. We had a couple of hospitals that were running low on ventilators, and some of the hospitals in other parts of the state that weren't seeing a significant number of COVID patients were able to, share some of those resources. So maybe they shared ventilators, maybe they shared staff, or maybe they brought a patient from one of those other hospitals up to their institution. So again, we focus on what unites us, not what divides us. And those areas where we do have differences, we got to figure out how we work through those. And so I think I said this earlier, but our business, this business of associations, it's built on relationships. As you said, we have 26, community hospitals. We have 5 specialty hospitals. But if a CEO announced today that they were leaving, retiring, moving to another job, every other CEO in the state would know it by the end of the day. And so if you have a new person, we all know that. And so we're able to make decisions. We're able to do the work that we do because we've built relationships. We know one another. We trust one another. And those relationships are so important. It's easy when everybody agrees, right? We all agree on this, so we can all say yes. But when the issues are more challenging, and the issues are becoming more challenging, as payment and all kinds of things, market forces, all of those kinds of things are coming into play. That's when it's so important that we've built those relationships, that we can actually sit down and have those, more challenging conversations with one another. How do we develop policy? How do we address those issues so that we can continue to work together for the betterment of our patients and our communities?
So you mentioned this phrase, you use this phrase, business of associations, and you had earlier referred to when you were at the American Hospital Association potentially being in conflict with, say, the AMA, the American Medical Association. I realize that I'm not trying to pose that you're in conflict with those organizations all the time, but obviously, so we have a New Hampshire Medical Association, which is kind of is the same relationship to the AMA, right? So they represent the interests of physicians in the state. We have a New Hampshire Nurses Association that represents interests of nurses, and so sometimes those interests are going to align, right? Mm-hmm. So the Nurses Association is going to have align with the interests of the hospitals. Sometimes, but nurses are an input for hospitals, so they're a cost to hospitals. Right. So there's naturally going to be some conflict of interest between those. I'm just kind of curious. not to dig into the conflict, but more about kind of your ecosystem of associations. I'm curious about how you think about that. Like, so there's you representing the hospitals, there's another organization representing the physicians, the nurses, and so forth. How do you look at that? How do you see that landscape, and how do you interact with those other organizations?
So yeah, we work very closely with the medical society, with the nurses association, the nursing homes, the home health aides, the community health centers, and a host of others. And it's really, I think the opportunity to leverage our own message. So if we can work with them on certain issues. In fact, the Hospital Association, the Medical Society, and the Nurses Association just recently issued a joint letter urging all Granite Staters to wear a mask and social distance and all of those things, because we can build the message bigger than just any one of us. So, we work on a lot of things. We spend a lot of time talking to one another. Again, building those relationships, working together. There will be times when we do have differences, and we have to work through those. But I think we have more alignment. Certainly in New Hampshire, I know some of my peers around the country have much more conflict with some of their other sister types of associations. I don't think we've had that same kind of relationship because, frankly, we have to find ways to work together, because if we can do that, if we can do things that benefit our patients and communities, it benefits hospitals, it benefits doctors, it benefits nurses, and the like. And so that's really the framework with which we kind of think about it. And again, as I think about all the things in the COVID environment, being able to leverage our own message with others is so important. And in fact, that letter that we did just a week or two ago, we got tremendous coverage of that by the media. And I think a lot of that had to do with the fact that it wasn't just one of us, it was all three of us. And so the media really focused on, wow, the doctors, the nurses, the hospitals are saying this. This is really something that's newsworthy that we ought to focus on. Now, if we had done it ourselves, maybe they would have caught on just because it's COVID and it's so important right now. But I think that really made a difference.
So one of the kind of unique things about New Hampshire that I think most people don't know is we have the third largest deliberative body in the world, right? So talk about that a little bit and how that affects kind of your business and what you do.
Yeah. So I worked in Washington. I lobbied the Congress. We had 435 members of the House of Representatives for 300 some million people. And I come to New Hampshire, 1.3, and we've got 400 House members. And the funny thing is, where do you find them? They don't have offices, most of them, other than leadership. Right. So you're really sort of chasing them down the hall, trying to find them. But here's the thing that I think is what makes New Hampshire unique. Obviously, as I said, this local control, community focus. That's what generates 400 members of the House, is that real focus on, I want this person to represent me. And from a lobbying perspective, it's a heck of a lot easier to lobby the Senate. There are 24 of them as opposed to 400. You can actually get your arms around 24 legislators versus 400. But what's really important about the work that we do, obviously, we have people in our staff who lobby every day. I go up to the legislature. I testify. I speak to legislators. But it's so important that not just I'm doing that or that our staff is doing that, but that our members are doing that. And I'll give you an example of why I think this is so important. But if I'm sort of providing that message about why we support this bill or why we support that bill or why we should oppose this one or that one, they expect to hear that from me, right? I'm the hired gun, the hired lobbyist. So of course I'm going to tell them that. But when the person from their community that they represent tells them those things as well and can help them understand why that's so important to their community, to their ability to deliver care to their patients, to employ the doctors and nurses and others in their community. That's what makes the lobbying effort so powerful, because it's that local voice. When they hear it from the administrator, the trustee, the nurse, the doc, those things make such a difference. And I'll just give you an example. Medicaid expansion. When the federal government expanded the Medicaid program under the Affordable Care Act, many states jumped on board right away. The federal government was going to cover 100% of the costs right away. And then over time, after 3 years, the state was going to have to pick up a portion of that up to 10%. Well, everybody knows sort of what happened. The Affordable Care Act became a political football, and Democrats liked it, Republicans didn't. And we had, at the time, in 2014, we had a Republican Senate, a Democratic House, and a Democratic governor. And there was this effort to expand the Medicaid program. And we needed to get the legislature to go along. The House was likely going to was there. The governor was there, and we had to get the Senate to go along. And ultimately, what we did was we decided to, instead of making this a lobbying activity out of Concord, we were going to bring everybody to Concord and go talk to legislators here and tell them why it was so important. We said, no, that's not where we want to do this. We want that to happen back home. And so we invited legislators to come in small groups to talk to their local hospitals about why was Medicaid expansion important? What did it mean in terms of coverage? It meant that people who were coming to the hospital who didn't have insurance, how that was resulting in uncompensated care and was costing the hospital money and an inability of the patient to get the kind of routine primary preventive care. So that they had to wait until they were in crisis and then they came to the hospital. And we talked about those issues. We didn't say support the Affordable Care Act. We talked about why that was important. And, almost to a T, we would get legislators, Republican legislators would say, well, gee, that sounds like a really good idea. Why we should do that? And then we'd, kind of say, well, that's Medicaid expansion under the Affordable Care Act. And then you'd kind of get this, oh, wait a minute. Well, that's really good. If we can do that without having to pay for it, we'd support that. And I'm absolutely convinced that effort to communicate at a local level, at home, was so fundamentally important, because you had many of the very conservative groups who were opposing the Affordable Care Act, sort of waiting to pounce when everybody got to Concord. But once legislators had come to Concord, and we would have lost the ability to really shape that conversation. And I'm so thankful that we were able to do that in a way that I think, in some ways sort of took the politics out of the conversation. Now, of course, when New Hampshire ultimately had to reauthorize Medicaid expansion and had to come up with the money to pay for it, then legislators said, well, we'll keep it, but you got to figure out how to pay for it, because we're not going to use our own money to pay for that, which is can be a frustration for those of us on the policy advocacy side. But we ultimately were able to come up with a way to make it happen. Hospitals stood up and said, we'll make voluntary contributions to cover the state share. So along with hospitals and insurance companies, we were able to come up with those dollars to pay for that reauthorization. Ultimately had to make another shift because of the new administration didn't like those voluntary contributions. But to this day, hospitals continue to make contributions to support state programs, and right now supporting programs that are used to fight substance misuse services because of our commitment to making sure that Medicaid expansion continues and that people can get the coverage that they need, which again is fascinating. We did a series of roundtables after Medicaid expansion was passed, and we were out talking to the hospitals and hearing from the doctors and nurses who would say, I had a patient who I would normally see at least once a month in the emergency room. So someone with diabetes didn't have insurance, they didn't get the insulin and other things that they needed to manage their disease. See them in the emergency room, we'd often have to admit them. But 6 months since Medicaid expansion, I haven't seen them. Not because they're going someplace else, but because they're not coming into the hospital. They're able to get the care that they need. And to me, that's what Medicaid expansion was all about. Helping to move the patients to a better place so that they can get the primary preventive care that they need. For many of us, expanding coverage has been a hallmark of the work that we've done in our career. And, it's often, been, we add coverage by onesies and twosies. It's not very often that you get to add, in New Hampshire, 50, 60, 70,000 people to the coverage rolls like we were in Medicaid expansion.
I wanted to ask you along the lines of expansion of coverage and getting coverage with COVID. One of the things we've seen is an expansion of the use of telehealth. Mm-hmm. And I wanted to ask about your thoughts on telehealth, the future of telehealth. And one of the things that I found fascinating that I learned spending some time up at Dartmouth Hitchcock and talking to their connected care program up there was, I'd always kind of thought of telehealth as doctor through my iPhone, but Dartmouth and their program and other programs, of course, as well, are providing a lot of provider to provider support. So tele ICU, where the Dartmouth ICU team provides support to a hospital, a critical access hospital up in the North Country that maybe doesn't have a staff neurologist or somebody else to. I'm curious, and obviously the provider to patient telehealth programs are also really important for access in particular in rural communities. New Hampshire, much of New Hampshire is. What are your thoughts on kind of we've seen an expansion of those policies and allowances for those policies with COVID, but kind of going forward, how do you see that changing, expanding? Do you see that becoming permanent? Your thoughts on that?
Yeah. So I think the kinds of things that you were referencing in terms of sort of the tele ICU and sort of the provider to provider, I think that's going to continue to grow. And we've seen a fair bit of that around the ICU. We're seeing that in terms of behavioral health, right? So a small hospital may not have a behavioral health provider. So having that ability to connect has really been important. But the sort of the shift and the expansion of telehealth, we've been working at trying to expand telehealth for years, and we've had challenge after challenge. Part of that was because of technology. Part of that's because of reimbursement. Part of that, the federal government wouldn't really recognize telehealth for Medicare beneficiaries in urban areas. In rural areas, yes, but not in urban areas. When the pandemic hit, it really sort of the silver lining, if you will, was the ability to just fast pace a lot of those kinds of changes. So allowing for all kinds of telehealth modalities, a cell phone, an iPhone, Zoom, those kinds of things were really, really important. But the ability to get paid for doing that, the ability to see patients, I think that it's here to stay. It's not necessarily going to become a replacement so nobody's going to go into a doctor's office anymore, but it's going to become an integral part of the healthcare system. And in fact, one of the things that we've heard over the last several months is, for many of those patients who were receiving treatment or counseling for substance use or mental health services, adherence to appointments has gone way up because patients can actually have their appointment online, and they don't have to get out. Sometimes transportation, getting to an appointment can be a challenge for some people. Being out in the pandemic, is another issue. The stigma of mental health and substance use services, the fact that people are able to continue to get those services, adherence to appointments has gone way up. So those things are really important. I think Medicare's working to lock in some of the changes that they've made. Likely Congress will need to step in and do some things. We were very fortunate here. The governor issued a very strong executive order that allowed for all that. The legislature actually sort of codified a lot of that in statute the end of the session this year. So we've made a lot of progress, but I think we have more work to do. But I think had we not had the pandemic, I don't know that we would have seen the acceleration of telehealth in the way that we did.
I want to wrap up on a few questions that are more leadership oriented. You've talked a lot about developing relationships. Now, you as an organization, you don't have the ability to direct your members. You spend a lot of time influencing members of Congress. How do you build those relationships? How does somebody become influential?
You know, it's a great question. It's one those of us in these roles think a lot about. I think part of being influential is sometimes not always, separating oneself from the goal and the objective. Not taking oneself too seriously in the work that we do. My job is to help lead this effort, and at the end, if we're successful, I get to turn to my members and I get to tell them what a great job they did, and their involvement, their engagement, led to that victory and all of that. And if we're not successful, I get to stand up and I get to say, we need to do. We could have done. I could have done things differently, and the like. But I think fundamentally, to me, if I think about leaders that I've known, they're people who they're willing to stand up, right? They're willing to stand up for a cause, for an issue, speak out. But they're also people who are fundamentally good listeners. I think, one of the most important things that I've had to learn in my job is to be a better listener and to not always respond with an immediate answer, and sometimes respond not with an answer, but with a question, and to help us think through that, thorny problem, right? Is to help them, our members, come to those, conclusions. It's better if somebody else can come to that conclusion on their own. If you find a way to work through that, then to tell them, here's the answer. I know sometimes people can get frustrated with this work because there's a lot of process. We got to meet with this group. We need to meet with that group. But at the end, we want everybody to say, yeah, that's right. That's the answer. And one of the things that, one of our payments, our reimbursement is always a sticky issue. And we've had some challenges with something called the Medicaid enhancement tax. It's the Medicaid DISH program. It's a long history. I won't go into it. But a number of years ago, there were, lawsuits and the like around all that. And we ultimately ended up having to settle these lawsuits with the state. And we did that not because I walked into the room and put a piece of paper on the table and said, here's the solution to the hospitals. But, we literally worked, in this building, in conference rooms around here, and worked through those issues. We had, big hospitals, small hospitals with very different interests and perspectives. And, when, as they say, when the chicken wings on the platter get fewer, the elbows get sharper. And boy, we had some real challenges, but we were able to solve that problem because we created a solution that not that everybody got everything they wanted, but everybody understood what we got at the end and what it took to get there. And I have to say, that was really a defining moment for us, and for me, I think, in really bringing our members together and helping them understand the value of the association, of working together through the association to solve, big problems. It's not easy. It doesn't happen overnight. Sometimes it can be messy, but if we can do that, we have, greater opportunity for lasting, unity than if we just said, here's the answer. And I think, again, that, to me, that is what allows me as the leader to be able to kind of bring our members together so that, I certainly hope they feel that, I'm somebody that's going to listen, that's going to help try and synthesize and bring people together. If somebody's looking for me to solve all their problems, to say yes to everything that, that they want, that's probably not going to be a very fruitful relationship. But if they know that they can come and they can work together, they know they're going to have an honest opportunity to make their case and to at the end of the day, we're going to come up with the solution that best fits their needs and everyone else's. I think our members are willing to be a part of that. It takes a lot of effort, and I think one of our biggest challenges is getting our members to spend their time with us, to be part of the conversation that we have, because they're busy. Running a hospital, a healthcare system is a big job, and for them to spend time with us takes away from their work at the hospital. But if we can do the work here that develops the right set of policies, it helps them and the work that they're able to do back at the hospital.
So thinking about your career, all the leadership work that you have done and the things you've learned, was there a lesson you had to learn kind of the hard way that you now reflect on and you've built on? So something maybe that didn't quite go the way you thought it would, and you've built and you've learned from that and built on it.
One of the policy things that we attempted to do a number of years ago, as hospitals are looking to affiliate, partner, potentially merge and create larger health systems to really spread their reach and their ability to serve their communities. There's been a lot of talk about how do we regulate that, right? You got to get regulatory approval at the state. You got to get regulatory approval at the federal level, and it's costly, it's time consuming. And what we said is, why don't we build that process so that we do that here in New Hampshire? Who better to make the decision about what's in the best interest of New Hampshire? Somebody on State Street in Concord, or somebody on Constitution Avenue down in Washington who may not know where Concord, New Hampshire is. And I think that it was the right set of policy questions, but in the end, we didn't have consensus among our members. And so we had members, sort of on opposite sides of that question. We were able to get something through the Senate, because as I said, you can work with the Senate. We had good leadership in the Senate. We were able to get something through there, but we were never able to get it across the finish line in the House. And learning to navigate a 400-member House is a very different thing than a 24-member Senate. So ultimately, while we got something through the Senate, we never got it through the House, and we've never been able to kind of come back to that. And it's really, pretty fundamentally important as we think about how healthcare is being organized and delivered in the years ahead. How organizations are coming together are a pretty important question, and how ultimately that oversight is provided is important as well. And again, I still believe that was the right policy approach. We were just not able to get it across the finish line.
Well, I know you need to go, but so let me finish on this last question. So I teach a lot of young folks. How would they know that this is the field what is it that is in someone's character that this would be a good fit, the world of lobbying and policy and so forth?
Yeah, lobbying gets a bad rap, right? As I always say, don't tell my mom I'm a lobbyist. She thinks I have a real job. But lobbying it's all about sort of telling a story, right? It's telling the story about what it is that you do, what you can do, and how you can make a difference. And I think less of myself as a lobbyist, and I think of myself more as an advocate for hospitals, and somebody who has an opportunity to make a difference. And from a policy perspective, you have an opportunity to make a difference on a pretty big scale. Hospital leaders do the same thing, and they affect the lives and livelihood of people in their communities, and which is incredibly important. And from my perspective, we do that on a much broader scale. We have the ability to do that across all hospitals, across the entire state, and to some extent across the country. And so, again, I always think about, do you like to learn? Do you like to push yourself to become and be able to do different things? Do you want to, kind of give back and make a difference, do something that's bigger than just yourself? Those are some of the qualities that I think, draw me to this field, and I think can make you successful if it's something, that you're interested in. And a lot of people think, well, gee, how do I become the president of the Hospital Association? Well, for students, that's not the place you want to start. You want to start at a place where you can sort of kind of get on that ladder and take that first step. And within healthcare organizations, there's lots of opportunities. Hospitals, long-term care, community health centers, substance use. There's lots of things. State government, federal government. Those are great opportunities to learn. The great opportunity I had was, I was making no money in Washington when I started out, which was, that was the bad news, but it was also the good news. While there were a ton of people willing to work for no money like I was, there were other people who weren't. And so, I had the ability to sort of jump in and work as hard as I could. And good people are hard to find. You work hard, people are going to notice that, and you're going to have opportunities. It may not, be your first job, maybe your second job or your third job, but if you, work your tail off and try and learn and do more and more, I think that there's no ceiling to folks in terms of what they're capable of doing. And again, I've had a great career. It's been unbelievably satisfying to me to be able to to serve and to help people, whether it's students or others along their career path. One of the greatest compliments you can get is when one of your team members gets a promotion or gets a job and goes on and does something more exciting or more challenging with more responsibilities. Hopefully that reflects on you, that you've been able to give that person the ability to step up and to take on new roles.
Steve, thank you so much for your time today. I've really enjoyed learning more about your organization and everything you do.
Thank you, Mark. This has been fun.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again soon.